Ladies and gentlemen, welcome to Triple N Media. I am Dr. Nik Nikam. This is a cardiology lecture series, and in this presentation, we are going to be talking about supraventricular tachycardia, diagnosis and acute management. Let us begin. Supraventricular tachycardia can be coming from a number of sites. So based on that, we are going to categorize them into different groups. The first one is the sinus tachycardia, which ranges from 100 to 160 with a 1-to-1 conduction between P and QRS. Then we have a regular RR interval, regular P waves, QRS narrow. Then we have a paroxysmal supraventricular tachycardia with a rate ranging from 160 to 225, and it could be 1-to-1 or 2-to-1 conduction, regular PR interval. The P waves can be variable depending upon how many beats are conducted, and the QRS is generally narrow unless there is an underlying conduction disturbance. Atrial flutter. The atrial rate is 225 to 320. When we are looking at electrocardiograms, first we look for the rhythm. Second, we look for the rate. When we are looking at rate, we are looking at atrial rate and we are also looking at ventricular rate. They need to be looked at independently. Then establish a relationship between the P cycle and the QRS cycle or the R cycle. Then we come up with these numbers. Atrial flutter could have 1-to-1 conduction. That means it's 225 to 320 beats per minute conducting at 1-to-1 conduction, or it could be 2-to-1, which is most commonly seen in untreated atrial flutter, where the ventricular rate may be like 150, 160. When a patient comes with a chronic atrial flutter who has been on drugs, their ratios can be 4-to-1 or even 5-to-1 depending upon the degree of AV block. The RR intervals are variable. The P waves have the typical sawtooth appearance. QRS can be narrow or wide depending upon the rate and also depending upon underlying bundle branch block. Atrial fibrillation is generally with the atrial rate greater than 320. We have a variable conduction. We have variable RR interval. The P waves are not clearly discernible, and the QRS is generally narrow unless there's a underlying bundle branch block or you are dealing with a patient with WPW. Now let's talk about multifocal atrial tachycardia, which is a very uncommon arrhythmia that we are going to encounter. But nonetheless, if you are studying for cardiology boards, you may see one of these electrocardiograms on your EKG section, where the multifocal atrial tachycardia ranges from 100 to 250, and this is seen in the setting of a patient with a chronic obstructive pulmonary disease, and generally it behaves like a sinus tachycardia, except for the varying morphology of the P waves from beat to beat. If you see 3 distinct P waves without the presence of premature atrial beats, then you need to think about multifocal atrial tachycardia, especially if you are dealing with a patient with chronic lung disease characterized by right axis deviation, maybe low QRS voltage, things like that. Junctional tachycardia is usually at a rate from 100 to 180 beats per minute. The conduction is 1-to-1 or sometimes 2-to-1. Whenever you see junctional tachycardia, you need to think about the P morphology, which can be totally buried in the QRS complex. It could be preceding the QRS complex, or it could be following the QRS complex. In either case, it will be very close to the QRS complex, so the PR or the RP or RP interval will be very narrow. And similarly, the QRS complexes are narrow most of the time. In patients with the WPW, the rates could be anywhere from 100 to up to 400 beats per minute. Could be 1-to-1, 2-to-1, 3-to-1 conduction, but the RR interval is going to be variable. The P wave morphology is going to be upright. The characteristic feature will be the delta wave. to summarize, first you look at the rate. If you can't clearly measure the rate, look at the top part of the EKG, which has 3-second markers. You measure the number of beats in 6 seconds and multiply that by 10. That will give you the average heart rate. Once you have established the heart rate, the second point is to look at the P cycle, the atrial contractions. Then look at the R cycle. Then you try to combine them together and see what kind of a relationship they have. And based on that, we can pretty much narrow down the diagnosis to 2 or 3 entities. Whereas if you are having a heart rate between 150 and 160, and it looks like sinus tachycardia, you should always think about atrial flutter. Look for the flutter waves, most often seen in lead 2 or V1. Here are some of the drugs that are used orally and intravenously for managing rate control. We are talking about rate control. There are antiarrhythmic drugs which keep the patient in sinus rhythm in chronic atrial fibrillation. But here, basically, we are trying to control the rate. So some of the drugs that are available are like atenolol, 25 to 200 milligrams given once or twice daily. Metoprolol succinate, ranging from 25 milligrams twice daily to all the way 100 milligrams twice daily. Diltiazem, which is a calcium channel blocker, which is given as 80 milligrams every 8 hours. Or you have diltiazem CD, which can be given as 120, 240 or 360 milligrams daily. Verapamil has a similar dosage. The advantage of verapamil is it can be given intravenously. It has a profound effect on the AV node. It reduces the ventricular conduction in patients with atrial fibrillation. Verapamil also depresses the ventricular function, and it should not be used in patients who have greater than first degree AV block. If you see second degree AV block or high degrees of AV block, verapamil should be avoided. It also should be avoided in patients with left ventricular ejection fraction less than 40%. Diltiazem is very frequently used in patients with atrial fibrillation with a rapid ventricular response, where you give 15 milligrams of bolus followed by a drip for 24 hours, ranging from 5 to 25 milligrams per hour. The moment we start these patients on diltiazem drip, make sure that we use other agents like beta blockers or amiodarone to have a long-term control of the rate and rhythm. Digoxin is given as 1 milligram bolus in divided doses like 0.5 milligrams followed after 6 hours by a second dose of 0.25 and a third dose of 0.25, and then closely monitor the rhythm, the rate, ectopic beats, and electrolytes and kidney function. Amiodarone, if it's given intravenously, it has to be given at 1200 milligrams IV at a rate of 1 milligram per minute for 6 hours, and then 0.5 milligrams per minute for the next 18 hours. But remember, the cost of amiodarone could be $1,200 per day. On the other hand, we can give amiodarone 200 milligrams twice daily or once daily. Sotalol is an antiarrhythmic drug which is used to control atrial fibrillation, to keep them in sinus rhythm. It is also used in patients with ventricular tachycardia. Flecainide is used to keep patients in sinus rhythm when they are having atrial flutter. It is 50 milligrams twice daily. And dofetilide is, again, propafferone is used for atrial flutter for rhythm control. We have rate control and rhythm control. These two are separate entities. Dofetilide is 500 micrograms every 12 hours, but a lot of these antiarrhythmic drugs like sotalol, dofetilide, all these prolonged QT interval, so the QT interval needs to be monitored very closely. If their QT intervals are greater than 500 milliseconds, then the dosages needs to be adjusted. Procainamide has a unique place in the management of patients with WPW. with the supraventricular tachycardia, when it's given intravenously, it controls the rate because it is one of the few drugs that blocks the accessory pathway in patients with WPW. This is a drug which is not used very commonly, but it is an anti-arrhythmic drug, ibuprofen. All right, let's move on. Supraventricular tachycardia versus ventricular tachycardia. Supraventricular tachycardia, the rates can be 160 to 300 beats per minute, whereas ventricular rate is generally 160 to 250 beats per minute. It is irregular in patients with atrial fibrillation, atrial flutter, multifocalateral tachycardia, and WPW. The rhythm in ventricular tachycardia could be irregular, but more often it is regular in ventricular tachycardia. In junctional tachycardia, of course, we're going to have narrow Qrs complex. Same thing with atrial tachycardia. Fusion beats are not seen because all these beats are coming from the supraventricular focus. But if we see fusion beats, that may be highly suggestive of ventricular tachycardia, or could be bundle of his tachycardia, because you have a atrial beat fusing with the ventricular rhythm or the ventricular beat in the rhythm. Carotid pressure will generally slow the RR interval, thus revealing atrial flutter waves, and sometimes it may terminate paroxysmal supraventricular tachycardia, whereas ventricular tachycardia has no response to carotid sinus pressure. All right, so how do we diagnose a supraventricular tachycardia? If it's a narrow QRS or a wide QRS. Let's say we are looking at a narrow QRS tachycardia with a rate ranging from, let's say, 100 to 225. The next thing we look for is regularity. If it's a regular tachycardia, first we look at the regularity of the RR interval. If the RR interval is irregular, then you're looking at atrial fibrillation, atrial tachycardia or flutter with variable AV conduction, and multifocal atrial tachycardia. If the RR intervals are regular, and if you have clear-cut P waves, you could be looking at paroxysmal atrial tachycardia. It could be, if the atrial rate is greater than the ventricular rate, then it could be atrial flutter or atrial tachycardia. If the atrial rate is not greater than the ventricular rate, then you look at the RP interval. If the RP interval is less than 90 milliseconds, that is, if the P wave is coming following the QRS complex, then you're looking at the AV nodal re-entry. Whereas if the RP interval is greater than 90 milliseconds, you're looking at atrioventricular re-entry tachycardia. Look at the terminologies here. AV nodal re-entry if the RP interval is less than 90 milliseconds, and if it's greater than 90 milliseconds, the RP interval I'm talking about, then we are looking at atrioventricular re-entry tachycardia. On the other hand, if the RP interval is greater than PR interval, then we are looking at the atrial tachycardia or paroxysmal junctional re-entry tachycardia or atypical AVNRT. Whenever these patients have irregular rhythm, we always think about using anticoagulation, especially in patients with atrial fibrillation, new onset atrial flutter, and in those patients we need to measure the CHA2DS2-VASc score. If the CHA2DS2-VASc score is greater than 2, then these patients need to be on long-term anticoagulants. Some of the IV medications that are available for managing patients with supraventricular tachycardia include adenosine, which most of us are familiar with, which is most useful in patients with paroxysmal supraventricular tachycardia or PSVT, where you give 6 milligrams IV bolus in 1 to 2 second duration, followed with a rapid saline flush. Since the drug has like a very short half-life, the bolus has to reach the conduction system as quickly as possible. Then this can be repeated with a 12 milligram bolus once, 1 to 2 minutes following the first dose, and a second dose after that, to a maximum of 18 milligrams intravenously. Esmolol, we don't use it very often, but it is 500 micrograms per kg IV over 1 minute, and it can also be given as an infusion. Very often in patients with atrial fibrillation with rapid ventricular response, we can use metoprolol or labetalol in boluses. The labetalol lasts for 2 to 4 hours, whereas metoprolol lasts only for about 20 to 30 minutes. Of course, the diltiazem bolus and infusion I talked about. So these are some of the drugs that we can use in patients with supraventricular tachycardia in terms of first controlling the rate, and in certain circumstances eliminating the rate altogether. Say, for example, in patients with paroxysmal supraventricular tachycardia. Amiodarone, the bolus is 150 milligrams, then the infusion is 1 milligram per 6 hours per minute. Infusion is 1 milligram per minute for 6 hours, and then 0.5 milligram per minute over next 18 hours. Ibutylide, here you have the dosage. You can look it up. Again, you need to watch for QTC interval. If it's more than 440 milliseconds, you need to avoid this drug. Okay, let's look at some examples now. We have a 26 years old patient. Palpitations started a couple of hours ago. Sweating, dizziness, blood pulse is 180, blood pressure 145 over 68, oxygen 96% saturation, and here is the electrocardiogram. What is your diagnosis and how would you treat this patient? Okay, I'm going to pause here for a second. When you are ready, continue the video, then we will continue with the discussion. Okay, here we see a rapid rate which is 165 as it was given to us in the earlier report, and we see a P here preceding each QRS complex. So there is a PQRS, 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 and the rate is faster than what you would expect for sinus tachycardia. Since this started all of a sudden without any warning, we are looking at paroxysmal supraventricular tachycardia. This is something which can sometimes respond to the carotid sinus pressure or vagal maneuvers, and if that doesn't work, it responds very well in majority of the cases. Adenosine 6 milligrams bolus followed by a flush. If that doesn't work, you can give 12 milligrams bolus followed by a flush, and hopefully that should resolve the supraventricular tachyarrhythmia. That's one example. Let's move on to the next one. Patient, 50 years old, palpitations started 6 hours ago, sweating, dizziness, mild heaviness in the chest, hypertension, diabetes, hyperlipidemia, BMI 35, obese patient, pulse 165 per minute, irregular, and the blood pressure is sort of borderline, oxygen saturation 98%. So what are we looking here? Pause the video for a second, and once you have made up your diagnosis, we can continue with the presentation. The first thing you need to pay attention is look at the RR intervals. Look at the RR interval here. This is different, this is shorter, this is longer, and this is different. So when you see an irregular RR interval, you should always think about atrial fibrillation first. That is the most common tachyarrhythmia, supraventricular tachycardia, that causes irregular ventricular rhythm. Sometimes you may think there is a presence of a P wave, but those are real tiny notches, and sometimes it may be a part of the T wave which can mimic P waves. So this is atrial fibrillation with a rapid ventricular response. So here we are dealing with a patient with some sweating, dizziness, heaviness. So this rate needs to be slowed down. There are different ways to slow the rate down. This is atrial fibrillation. It is not going to respond to adenosine. So the best thing to do would be to start this patient on cortisone drip, which is useful because this patient's blood pressure is borderline, but once the rate slows down, the blood pressure may spontaneously improve. The other option is to use a short-acting metoprolol, like 2.5 to 5 milligrams IV, and slow the rate and see how the patient responds. So that will give you some time to decide what to do. And once you start them on intravenous medications, we should always be thinking about starting them on oral medications for long-term control of the rate, especially in patients with atrial fibrillation. Here we can also continue on the drip until the oral medications take effect. Now let's look at another patient here, 70 years old patient, palpitations started a week ago. So this patient had palpitations for a week, sweating, dizziness, mild heaviness in the chest, shortness of breath, leg edema, and history of heart failure with reduced ejection fraction. Pulse 165, irregular, blood pressure borderline, and oxygen level is low. So let's look at the rhythm here. What does the rhythm look like? Here we have a distinct P wave preceding each QRS complex, but the PR interval is very short. So you wonder if we are dealing with a supraventricular tachycardia other than sinus tachycardia. Is this a paroxysmal atrial tachycardia? And whenever we see this rate of 165, the main thing we need to determine is if we are missing a hidden P wave between the two P waves, which could put this into atrial flutter. The main reason I'm showing this one is to think about atrial flutter or paroxysmal atrial tachycardia when the rate falls between 150 and 160. So here it is clearly visible P waves. It could be a paroxysmal atrial tachycardia. It could also be a junctional tachycardia with a short PR interval. The best way to decide what this is to do a carotid sinus pressure. If this is flutter, it may unravel the hidden flutter waves. But nonetheless, this patient has evidence of some increased voltage, maybe some left atrial abnormality, non-specific STT changes. So this could be sinus tachycardia because of evidence of heart failure, and controlling the heart failure may automatically improve this rhythm. Let's move on. 45-year-old patient, palpitations for 1 to 2 weeks, fatigue, mild dizziness, shortness of breath, edema, blood pressure 90/60, pulse regular. So let's see what this one is. So here we have an electrocardiogram. Just pause the electrocardiogram for a minute, look at what we are seeing, and see if we can come up with a diagnosis. Here, what we are looking is a rate, again, as we were talking about, in the range of 160. Anytime we have a range of heart rate between 150 and 160, we need to be thinking about sinus tachycardia. Is it paroxysmal atrial tachycardia? Is it junctional tachycardia? Or is it atrial flutter with 2-to-1 conduction? So let's see if we can find an answer. There looks like there is a P wave here, and there could be another P wave here. So if you look at the lead 2 here, there looks like a P wave here, there looks like another P wave here. If the P waves are not clearly discernible as it is in this case, you can do some carotid sinus pressure. When these flutter waves will just light up, then you know you're dealing with a patient with atrial flutter. When you see a patient with new onset atrial flutter, make sure the aim is not to convert this patient into sinus rhythm, which can predispose this person to embolic event. So the main purpose here is to control the rate. In this patient, we can use the regular drugs that we use to control the rate, such as diltiazem to reduce the AV conduction. We can also use metoprolol, and we can also use digoxin, which can help to control depending upon the severity of underlying medical problems. Okay, Here's one more patient, 50 years old. He was feeling dizzy at the parking lot. They took him to the emergency room. He was alert. He had palpitations on and off for 4 weeks. Fatigue, mild, this one, pulse 220, irregular, wide QRS, blood pressure is okay, oxygen. Okay, let's look at the electrocardiogram. What is this? Pause the video for a second, take a look at it, then we will continue further. So if you look at this one, it looks like ventricular tachycardia. You got a wide QRS complex here, and the rate seems to be regular, 160. Then this must be ventricular tachycardia. But it could also be supraventricular tachycardia with bundle branch block, especially left bundle branch block. So the rate now is 160, just like the other two electrocardiograms we saw. So we have to think about sinus tachycardia with left bundle branch block, or it could be paroxysmal atrial tachycardia, which is uncommon in a patient this age, or it could be atrial flutter with 2-to-1 conduction. It could also be AV nodal re-entry. In order to find out if this is ventricular or supraventricular, we'll look at the Qrs morphology and see if there's any evidence of a P wave suggestion anywhere. If you see a P wave, you see there's a notch here, but that's not really a P wave, so that's not a P wave. So yeah, this could be a P wave, this could be a P wave here, there's a P wave, there's a P wave, there's a P wave. Maybe I'm just imagining, but nonetheless, that's how you try to find out. If you are not really sure what it is, well, one thing we can do is do a carotid sinus pressure, and when you slow the rate down and you see the P waves, you can march the P waves on the QRS complex and see what exactly is happening. Supposing you do the carotid sinus pressure, and this happens to be atrial flutter with a 2-to-1 conduction, then we're going to see 2 P waves for each QRS complex. If this is just sinus tachycardia, the rate will slow down, then the P waves will be separated from the T waves, then you can see the clear-cut P waves. Then you can see the clear-cut P waves preceding each QRS complex. Similarly, if it's AV junctional tachycardia, then this is unlikely to be AV junctional tachycardia or AV NRT because the RP interval is greater than 90 milliseconds. Remember, in one of the charts I showed you, if it's less than if the PR interval is less than 90 milliseconds, then it is AV NRT. Whereas if the RP interval is greater than 90 milliseconds, it becomes AVRT or atrioventricular re-entry tachycardia. But we can't be clear just based on this electrocardiogram. So we need further evidence in this patient. Let's go back to the history and see. So the blood pressure is 110. The patient is symptomatic. I think a couple of things we can do is to slow the rate down temporarily for diagnostic purpose, which can be done with the carotid sinus pressure or with a dose of beta blocker. Then once we know what the diagnosis is, then we can start on the appropriate treatment. It is unlikely to be tachycardia if the patient has adequate blood pressure and adequate oxygen saturation level, but it could be, you just cannot exclude it. Keeping these things in mind, you approach this in a systematic manner. First look at the rate, then rhythm, then look at the P waves, look at the QRS complexes, look at the relationship between the P and the QRS complexes. If they are not clearly visible, try some maneuvers like vagal maneuver or carotid sinus pressure or intravenous metoprolol to slow the rate down, to look at the P waves and the QRS and their relationships, and then determine what you're dealing with. After that, you can plan your treatment. All of this should not take more than 5 minutes, I would say. And here are some bonus EKGs. This is basically a sinus rhythm at a rate of 105. We got PVCs, and incidentally, there's a paced beat here. And we also have STT changes, suggest you have some degree of subendocardial ischemia. All right. And here we have an irregular rate which is very rapid. It's greater than like 160 or 170. Now we are dealing with atrial fibrillation with a rapid ventricular response. So that's the case. Now here we are dealing with a classic flutter waves, which has already revealed itself by slowing the ventricular conduction. So this is sort of a atrial flutter with controlled ventricular response, even though the conduction rate varies from beats to beat. All right, here's another example. This is sort of a complicated electrocardiogram, but let me explain it to you. This is an acute inferior myocardial infarction. On top of that, we see Q waves in 1 and AVL, which is very unusual because they are describing two different areas or the regions of the myocardium. So what has actually happened here is they have inverted the right arm, left arm leads, which has caused this positive deflection in AVR and a negative deflection in lead 1. When these leads are reversed, you will see that we are dealing with an acute inferior myocardial infarction. In fact, this patient was having an acute inferior myocardial infarction. And here's a final bonus electrocardiogram. Can anyone guess what this is? Well, this is atrial fibrillation with a WPW, because look at the RR intervals, which are grossly irregular. I mean, that's a quick diagnosis of that one. All right, ladies and gentlemen, you have been listening to Supraventricular Tachycardia, how to approach the diagnosis, and what are some of the most commonly used treatments, modalities, and the various drugs, the form in which they are administered. I hope this has been useful to you. Please do subscribe to our YouTube channel, and we will see you next time. Thank you so much for your time.